and good afternoon. My name is Zach Mizell, and I'm Associate Professor of Emergency Medicine at the Perelman School of Medicine at the University of Pennsylvania. And I'm also the Director of the Policy and Dissemination Core, which is based here at Penn and at the Leonard Davis Institute. The Policy and Dissemination Core is the part of CHERISH. And for those of you who are not familiar with CHERISH, CHERISH is the Center for Health Economics of Treatment Interventions for Substance Use Disorder, Hepatitis C, and HIV. Funded through the NIH as a National Institute on Drug Abuse Center of Excellence, CHERISH is a multi-institutional center located at Weill Cornell, Boston Medical Center, Boston University School of Public Health, the University of Miami, and also here at the University of Pennsylvania and the Leonard Davis Institute. Its focus is to develop and disseminate research at the intersection of health economics, health policy, and health outcomes related to issues of focusing on the treatment of substance use disorder, HIV, and hepatitis C. The Dissemination and Policy Core is located here at LDI, which is Penn's hub for health policy and healthcare delivery research. And I want to thank Bruce Shackman, who is the overall principal investigator for CHERISH, and Rachel Werner, who is the executive director of LDI, for really supporting and hosting today's conference. So a quick word about today's conference, very excited about it, titled Using State Licensing Standards to Improve Access to Medications for Opioid Use Disorder. The idea for the conference came from a few sources. First, we, as many of you may recall, if you were with us at our previous CHERISH conference about 2.5 years ago, we explored some ideas related to the value of opioid use disorder treatment and how to consider reducing low value or no value care, either through payments and other sources. We sort of left off very much thinking about new opportunities and levers for which we could improve the quality and value of care. Then, along with the support from Arnold Ventures, a team led by Brendan Soliner from the Johns Hopkins, who you'll hear from today, as well as our team, convened a group of experts to consider model regulatory licensing opportunities at the state level for residential care. The product is a draft that was sent to you and is in the chat here, or will go up in the chat, that you could take a look at. And it's draft language that really thinks about and focuses on regulation as it relates to licensing standards for residential treatment. So this conference is really meant to begin the discussion on this topic in a wider form and to share the ideas and experiences of both policymakers, researchers, as well as providers. We have, as you saw in the initial slide, a very exciting lineup, a keynote speech, and then followed by 2 panels, one of which focuses on actual policy and progress towards state licensing standards, and then followed by research and data considerations on the same topic. So I want to thank, again, the National Institute on Drug Abuse, Arnold Ventures, and our panelists today, and our experts who weighed in on the many steps to get here. I particularly want to thank my partner in crime on all things related to dissemination and policy, Janet Weiner, who is the Director of Policy at Leonard Davis Institute, as well as Mavis Frimpong, Tracy Chupik, and especially Nadia Browning, who is really the leader in all things operational to get this conference off the ground. So thank you all. And without further ado, I'm going to introduce our keynote speaker. Very, very excited to have Rebecca Gee, somebody I've known for many years. Rebecca Gee, Dr. Gee, has served in many leadership roles, but is currently the Chief Executive Officer of Healthcare Services for Louisiana State University Health. Formerly, she served as the Secretary of the Louisiana Department of Health from 2016 to 2020. And under her leadership, Louisiana did a lot of amazing things and really led the country across a variety of areas, including Medicaid expansion, a Medicaid dashboard to access healthcare services, and implemented a comprehensive plan to address the opioid epidemic in Louisiana. She's trained as an obstetrician gynecologist and health policy expert, and has served in many state and national leadership roles. And in 2017 was elected to the National Academy of Medicine. Most recently, she founded and is leading a new venture called Nest Health. And I'm sure there'll be more to come because everything that she does is so exciting and innovative. So stay tuned for Nest Health. So without further ado, Rebecca, you can turn on your audio and video, and we'll get going.
Good morning. Thank you so much, Zach. Can everyone hear me? Super. Okay. So it's so nice to be with you today, back home in so many ways. Penn is my former home. So many of you I've had a chance to work with, including Zach and his incredible wife, and I'm so proud to know him and to see the work that he's doing on behalf of some of the most vulnerable people in our country. Also wanted to thank the Arnold Foundation. I called John Arnold my fairy godfather once. I'm not sure he liked it too much, but he sprinkled money on the needs we had to address hepatitis C in our state so that we could afford to get medications to everyone who needed it. And he has, and his foundation have done just remarkable work, and for the right reasons at the right time. Wanted to recognize Karen Stubbs, who's speaking after me, who without her efforts, her leadership, and my extraordinary team at the Louisiana Department of Health, none of this would have happened. Karen was really the engine that drove this. I was the person that went in front of her, taking down any barriers in her way, her offensive line, as it were. And then finally, Josh Sharfstein, of course, is phenomenal, wiping Bill Olson. But Josh, who is a selfless leader, has been my mentor, wrote our opioid response plan and didn't even put his name on it, didn't give himself credit. And his team obviously helped him, people at my department helped, but just it's so rare to find somebody who has no ego in this world, and he's one of them. And I'm so grateful to him for everything he's done for me personally and for the state of Louisiana and on behalf of this critically important issue. So I am an OBGYN, as Zach said. I am not an expert in opioid use disorder. I was previously chief medical officer for the Medicaid program for the state of Louisiana and led birth outcomes initiatives under Governor Jindal. So I learned, of course, about the importance of the opioid epidemic, have seen the struggles that my own patients have with addiction. But it wasn't until I became Secretary of Health that I really realized what a crisis we were in. That year, of course, as opposed to last year when we had double the deaths, we had around 1,000 deaths from opioid overdose. And at that time, prior to COVID, of course, this was one of the most critical issues that I faced. I knew that we had challenges getting access to care. As an obstetrician delivering babies in our local hospital, I had a patient. Some of the last times I was on call, I had patients come in needing help. And one particular woman came in with really wanting to change her life, was addicted to heroin, needed help. I spent the entire night calling our managed care companies who were supposed to be there to help her, and I was told, oh, we don't do that. And then when I finally got the right person, they said, oh, you've got to find a bed yourself. There was only one person in the hospital that prescribed Suboxone, and he wasn't there that weekend. And finally, this patient left without any help. And it was just shocking to me that in this country, our system is so broken that we couldn't provide someone who is ready for help with access to medication and the resources she needed to get well. And so as secretary, the governor and I realized that we had a problem that we needed to address. We did not have a comprehensive strategy to address the opioid epidemic. One of the first things that happened to us that really brought this to the fore was that Baton Rouge flooded. And in the first year of the governor's first term, the city of Baton Rouge, and in that year, about 65% of the state at some point was underwater or flooding, and we had to set up shelters throughout the state. And it quickly became obvious that one of the most important issues that people who did not have access to medications were detoxing. They were detoxing in our shelter facilities, and we needed to find a way to get people access to medications. One of the things that was really, I think, in terms of our first order of business of addressing this problem, was thinking about changing hearts and minds. And my talk is going to focus on a couple of key areas. One is, how do you change hearts and minds? How do you do regulatory policy? How do you change payment policy? And how do you have a quality improvement framework? But I think without the changing hearts and minds piece, it's hard to get to the other. So I think first and foremost, I wanted to recognize, and I think it was important to do this throughout the state as we address the opioid use disorder, that communities have been plagued by addiction and poverty and the sequelae of addiction for decades. And when it was communities of color who were impacted, and it was other drugs at that time, this was seen as a criminal issue. Help was not on the way. There was not, certainly there were individuals involved in helping, but there was not the kind of national recognition that occurred when all of a sudden it was people who looked like me who were dying of opioid overdoses. So I want to recognize that, but I think although it's not something we can fix now, it's something we can learn from. And I think it's important to take this moment when there's now broad societal understanding of addiction in a very different way to make the changes necessary. But it became easier, I think, to talk about it because the demographics of addiction shifted. But also, really, one of the things that I had to learn to do was to speak Republican and to talk to people, as this is one of the most conservative states in this nation. I am a Democrat and have a more liberal leaning, but had to learn to talk about these issues in a variety of communities. One of the things that made it easier, though, was that the hardest hit parts of our state from opioid overdose deaths were parts of the state that tended to be the most conservative. And so it became easier to talk to legislators and policymakers and local leaders because they might have had a cousin, a brother, a sister who had been involved in an addiction journey and needed help. And so I think that changing hearts and minds was easier, but it was important to talk about it, to talk about addiction as a disease, to really deal with stigma reduction, to meet with legislators and talk about the issue. One of the things we also did was get creative about how we framed the need for change. One of the things I thought was important and my team felt was important was to allow needle exchange so that we could reduce the risk of transmission of infectious viruses for individuals who were using drugs with a needle vehicle. And we were able to get a law passed because we went to the Sheriff's Association, very conservative group, and said, look, your folks who are working with you may be in a situation where they might be exposed to a needle. They might get infected. And isn't it in all of our best interests that our first responders, as well as individuals in society, have less of this disease? And we had a sheriff introduce the bill and it got passed. And we were in the very deep South, a state that allowed needle exchange, which was kind of an incredible story. But I think that changing hearts and minds has to start first. You need to solve any problem. And most of the problems I've worked to solve are in the maternal and child health space, but any problem you need to solve, you really have to convince people there's a problem. And that was part of our work. I think in terms of payment policy, I want to underscore that it's, a lot of states want to talk about providing resources and support, but if you don't have health insurance, you don't have coverage for healthcare, it's really an empty promise to say you're dealing with this epidemic. And that the first thing that the governor tasked me to do and that I did was to expand Medicaid. And today, over 600,000 people have access to Medicaid through the Medicaid expansion in Louisiana, the only Deep South state with a Medicaid expansion. But because of this, last time I checked, over 300,000 people have had access to substance use disorder treatment, the payment for that, and or mental health treatment for addiction. And that is critical. I really think without a way to pay for it, without expanding coverage, there's so many of the things that you'll talk about today are just not possible. And so it's important to recognize that and to fight for increased coverage where possible. The other piece of it that we really focused on was that we had 100,000 people who were involved in the criminal justice system. Most of them had addiction or mental health disorders. And it was really important that we focused on making sure that when people were leaving jails, were leaving correctional facilities, that it wasn't just a bus pass and a Hail Mary. It was, hey, look, here's a health insurance card. Here's your primary care doc. Here's where you can go to get your addiction treated. And I'm really excited to hear about states that have had some waivers passed recently. I think it was Maine, to be able to provide 90 days prior to release some Medicaid benefits. So I think that's a wonderful way to approach it, but that's important too, to think about coverage and how do we gain coverage, because without that, you can't have access to medications for opioid use disorder because the folks who need them most just can't pay for them. In terms of regulatory policy, my role in that case was really to go to Karen and go to others who are experts, to our physician community. And one of the things that I had done previously as chief medical officer for Medicaid was to create a lot more ways for physicians, nurses, social workers, behavioral health workers to come and give feedback to the department about what was needed. And it was clear that we needed to have a system of care that provided medication, not just detox, but medication and treatment in the same location. And so Karen and her team wrote an 1115 waiver that was approved and has been very successful and is now getting renewed, which I think is definitely a gold standard, which allows and requires facilities that provide assistance to individuals with addiction to also make sure that those facilities are providing medication, not just detox. And I think that's really important. The other was in 2019, we passed Act 425, which established requirements for residential facilities providing treatment for OUD and to make sure that they provided on-site access to medication-assisted therapy. So I think that's really important to make sure that your regulatory policies. Quality improvement framework, it's about measuring and making sure that we understand where we are. If we don't know where we are, we can't improve it. And so in a variety of key areas, we focused on measurement, first in the Medicaid expansion, showing people that it wasn't just about getting a Medicaid card, but here are the numbers of people being treated for addiction disorder. Here are the people who are being given access to mammography or colonoscopy, and having those by region, making sure people understand the impact of what you're doing. We created a very similar resource for our efforts in hepatitis C so that the community, our legislators, advocates could understand where we were. But we also created one for opioid use disorder, our Louisiana opioid data and surveillance system, which unfortunately this year has shown that over 2,000 people have died. So our problem is not getting better, but we're at least measuring it and able to show whether it's for grant funding, for policymakers, for advocates, for our clinicians practicing in communities across the state, where is the problem? Where do we focus on solving it? Are we getting better? Are we getting worse? Where are the deaths? What kinds of drugs are being used? What are the prescribing patterns? I think it's very important to have that type of data-driven view on this issue. And we have had, it was an interesting conversation when I went and met with the governor and talked to him, and he said, oh, wow, that's great. He and Governor Edwards, who is a Democrat, a West Point grad, and was just an incredible person to work with, really also understood the importance of data and how data can help you get resources. So he understood that this would help us get bills passed, would help us get grant funding, would help him when he gave talks and visited various parts of the state, understand what problems the people of our state are facing. And I think that that data-driven approach is very important, and it has also helped in Louisiana to address maternal mortality in a variety of other areas. And I think ironically is somewhat unusual for policymakers to focus on the data first and then change later, but I think it's important. So before I end, I just wanted to say, I think the work that everybody is doing to address the needs of this population is more important than ever. It is such an awful time for people who have addiction, who feel alone, who have mental health disorders. The COVID pandemic has gone on, and it's just compounded all of the underlying issues that were challenging prior to the pandemic. And I'm just hope that you have energy that comes from this conference, that you feel the support of others who are working with you, that you know how critically important your work is to those you serve. And I thank everyone for that work and advocacy. Zach, thank you so much for inviting me. It's such a delight to be back with you here at Penn, and for those who are calling in from elsewhere. And I know you're going to hear from Karen Stubbs soon, who is a remarkable leader, one of the best hires I ever made, and has continued to do phenomenal work, and can update you on what's happened in Louisiana in the last year and where things are. But just a remarkable team. And it really is the state public servants who work in the trenches who are the heroes, I think, in this fight. So thank you so much for having me. And I know that Zach may have a question, and there's some questions in the chat as well, so I'm happy to answer them.
Rebecca, thank you so much. Like, listening to hear you reflect on some of these achievements that you made, really in an environment that on its face doesn't seem like Louisiana would be potentially the state to lead in some of these, particularly some of these topics that often divide politically. And to hear you sort of reflect on how you were able to accomplish a lot through, what I heard was framing much of the work around quality improvement and the use of really good and solid data, and being transparent and bringing the right stakeholders to the table were perhaps part of that special sauce that allowed you to sort of make magic. I do have some questions about how you used both data as well as sort of this quality improvement framework, not just for substance use work, but also just in general, in terms of thinking about it from the perspective of, were you using those kind of big topics, data, quality improvement, to make your own decisions for you and your team, or to explain the decisions that you were making to your constituencies, or both? I don't know if you can reflect on that a little bit, but we spend a lot of time here thinking about how data and research and science can be used in a way that actually can promote good policy.
Absolutely. So it was both, right? So part of it is, if we're going to focus on a region of the state, we want to make sure that we're focused on the region that is heaviest hit, has the most overdoses, has the most overprescribing, fill in the blanks. But it also allows you to avoid bad policy. So a lot of companies came and met with me when I was secretary and pushed very hard to make an easy buck and open up a facility and detox people, and not have the kind of resources. And in fact, we had one in particular who was just extremely aggressive, and it was very hard to fight those kinds of bad ideas off. But the best ammunition you have is data. You can say, look, I understand that's what you want to do, but there's evidence that this doesn't work. There are better ways to go about it. And so using that data to fend off bad ideas happened in a variety of contexts, whether it was to really promote making sure that medication assisted treatment was available, or to fight off, building unnecessary proton beams at a cost of $150 million each, or freestanding emergency rooms. I think that kind of transparency around the data was important. I think one thing that Josh Sharfstein taught me as well is you can also put up something for public comment. So another way to get around really bad ideas is to say, look, here's our proposal. Let's get public comments. If you really have a problem with it, please get it out there and we can address it, but do it in a public way. I think that's important. But you do deal with what I call the Elizabeth Kubler-Ross, stages of data grief. You have a lot. It's important to show the data. Sometimes people don't believe it, especially if it's their own data, and especially if you're dealing with a provider or system and it's showing that provider or system is not doing a good job. They will question the data. They will say it's wrong. They will fight you on it. And so again, I think it's about working collaboratively, showing that things can be improved, demonstrating that they're optimal models, finding a gold standard treatment center or system in your state that has good data and comparing it to other data and saying, look, I know you say that you're doing a good job, but here's what Y system is doing and look at what they're achieving. Wouldn't you want to be more like them? And so it's not necessarily what I've found over the years is the stick is not as powerful as the carrot is when you can convince providers and communities that there is a better way that they can save lives by doing something different. They will change their practice. And I think the most powerful example of this was our birth outcomes initiative, where we lowered NICU stays by 10%. And that was a huge hit to hospitals. NICU is big money, but no hospital leader, physician or nurse taking care of moms and babies wants to make a baby go to the NICU on purpose. And when they know that's happening, they change. And I've seen it. So I do think that type of positive use of data, positive framing, showing quality improvement. Also, I hope that Don would accept me, Don Berwick is his disciple, and I'm on the board of IHI now, and I really think about quality improvement science in whatever I do, whether it's the new company I'm creating, Nest Healthcare, or other initiatives. It's about looking at data. Does the change that you're making result in an improvement? Can you measure that improvement? If it didn't make the improvement, how do you shift? And then how do you remeasure? So I think that is an important framework that we used, and we use data in our own department, and also created an institute to train members of our staff on Six Sigma, and really created a quality improvement culture at the department so that people who worked under Karen Stubbs and in Medicaid and in other areas would say, oh, look, how do I then start to relate to my own data? How do I think about this and understand it and be trained on it and develop new skills in quality improvement? I think that was an important part of our secret sauce for why we got so much done.
That's great. I think I imagine that perhaps your quality improvement sort of framework, which is pervasive obviously in healthcare systems, but maybe not necessarily in state departments of health, was unique. We probably have time for one question, and there is a question in the chat. So I'm going to read it, which it's asking you about, I'm just going to read it. With opioid prescribing at an all-time low, yet opioid overdose rates still extremely high, how do we shift policy making from a lens of prescribing to one of harm reduction, especially in a politically divisive environment?
Yeah, challenging. One thing I also wanted to say quickly before I answer that question was one thing that there are a variety of ways to get at licensure requirements and regulate how medication is accessed in treatment facilities. And so certainly you can legislate it, but one thing we did in Louisiana around NICU and maternity was to bring together providers, centers, policymakers, advocates, and we brought them together to come up with new licensure rules. And we involved the hospital association. And through that year-long journey, it took longer, but everyone was then bought in. They had said their piece, they had argued the points. And so by the time, and we didn't just pick people who were going to be on the team that we thought we wanted, but people who would disagree with us. And having that process and really working on it together is important. And I think the same type of approach could work in this area. So in terms of shifting, I mean, certainly, yes, I mean, there's been a recognition of overuse. And I don't know if any of you have seen the Netflix series, The Pharmacist, about Dan Schneider and his journey as a pharmacist when his son was killed as a result of his addiction. And his efforts to get overprescribing dealt with, which were just Herculean. It's an amazing story, and it's a great success story that we've had a decrease in opioid prescribing. I mean, I was taught to just give, opioids out after birth, 35 or 40 pills without even thinking about it. That's what we did. We didn't realize. So we've had obviously that's a great shining light in terms of policy improvement, but now we have other issues, I would say, that we need to address, including stigma, including harm reduction, acceptance of addiction as a disease that needs to be treated. And I would say, going back to hearts and minds, that's how you do it. You bring storytelling in, who has a son, a daughter, a friend, a sister who's been impacted, telling those stories. One of the things we did at the department was tell the stories of those who had been benefited from the Medicaid expansion, so that they were real. They were musicians, they were waiters in the restaurant you might have gone to. They had breast cancer, this was their story. I think that's really important in terms of changing hearts and minds. I also think the story about the sheriffs, sometimes you have to figure out what's in it for you, what's in it for them, right? What's in it for them? Is it safety in their community? I mean, one of the ways we really got people to get on board with our prisoner pre-release program is if we're able to reduce the need for drug use and addiction and mental health issues that cause the incarceration in the first place, when people are coming out, then communities will be safer, right? It's obviously benefiting the individual who is incarcerated, but it benefits the community when people aren't engaging in criminal behaviors because they have addiction and they have mental health disorders that are untreated. So I think it's sometimes you have to say what's in it for me approach. It's not just about which is my general, where my heart is, which is social justice. Healthcare is a right. We accept everyone. We love everyone. We care for everyone. That's not the approach that every policymaker has, and especially if you're in a conservative state. And so, understanding, first of all, listening to them. Where are they coming from? Understanding what motivates them, and then connecting on that. And I do think that we have to do more of that, obviously, in this country. There's a lot of talking past, not talking with. And I think the talking with and the working through it together is where we were able to get significant progress made.
Great. Well, I think we should think about going on to our next phase of the conference. Rebecca, thank you so much for joining us for a really, I think, inspiring keynote. Again, what you've been able to accomplish, I think, in a state that may not be on the top of people's minds in terms of making progress on these topics is pretty remarkable. And with that, I can go ahead and introduce our next panel. So once again, thank you again, Rebecca.
Thank you, Zach. Thank you. And I can't wait to hear what Karen has to say.